Hello friends, I am Dr. Ravikant presenting scar pregnancy. Here we can see a dense puckered scar, utrovesical fold of peritoneum is seen well deep inside the scar. Vasopressin injection is injected to the site of the scar to prevent the blood loss. We also tried reversible ligation of uterine artery on either side by shoelace technique. To expose the uterine artery, a fold of peritoneum between the round ligament and infundibulopelvic ligament is opened to enter pararectal space, that is lateral pararectal space. The dissection is continued further parallel to infundibulopelvic ligament to identify uterine artery. First, we have to identify the ureter, and then we can continue the dissection anteriorly, where we can see uterine artery crossing the ureter from lateral to medial side. It is safer to keep the dissection parallel to larger vessels and keep the surgical field clean so that blood staining does not obliterate the normal plane. So there we can see the ureter, which is identified by peristalsis. So in the medial fold of the peritoneum, we are keeping the ureter. Laterally, there is the internal iliac vessels and its branches. Care should be taken that these small vessels running in the free fold of the peritoneum should not be injured, which may stain the area and obliterate the anatomy. So there is the ureter, which is very well identified by its peristalsis. If you continue the dissection anteriorly, we will identify uterine artery, that the first medial branch of the anterior division of internal iliac artery, which crosses from lateral to medial side. Should not hurry in this plane to do the dissection. Take your time and identify the structures clearly. That is a loose fat that is covering the uterine artery. Bipolar shearers are very good to dissect in this plane, which give the enough amount of hemostasis, and a blunt tip, which is atraumatic for the dissection in this area, give a advantage in dissection in this area, preventing injury to the vessels. Very close to uterine artery, deep to it will be the uterine vein. Try to separate the uterine vein from the uterine artery to ligate the uterine artery. So that is the uterine artery I am holding in my left hand and doing the dissection. Loose cellular tissue that is present should be dissected, and the vessel that is running anteriorly is the obliterated umbilical artery. We should be very well clear with the anatomy, which structures we are identifying, so that we have to ligate the uterine artery, not other vessels, which is not necessary for this case. Scar pregnancy will have a rich blood supply from the uterine artery and its branches, which will minimize the blood loss during dissection. Though we have given a vasopressin injection at the site of the scar pregnancy, that may not be sufficient to reduce the blood loss during the evacuation of the contents of the scar pregnancy. So after keeping the dissection, now I'm trying to take a bite through the window between the uterine artery and vein below. It is safer to pass the suture, not the needle, below the uterine artery. But in this case, there was a little amount of fibrosis. We are finding difficult to separate the uterine artery from the vein. So instead of making a avulsion of the vessels, we thought of taking through the needle. But while doing this, extreme caution should be taken that we do not injure any other vessels. The most important vessel, which is very close here, is external iliac vein. While taking the bite or while taking the needle out of this place, we may injure the external iliac vessel. Care should be taken that we do not injure the external iliac vessel, which will invite more danger. Now we'll try to ligate the uterine artery like a shoelace pattern. How you tie the shoelace, which can be very easily removed after we completely evacuate the contents of the scar pregnancy. To tie the shoelace pattern, free end of the suture should be held little longer, and then the short end of the suture should be held midway between the tip and close to the site of the. We do not hold it at the tail end of the short stitch. Instead of that, midway between the tying side and the distal end of the short stitch. And then we will tighten it. We will not reinforce the stitch once again. Only one knot is tied, which is sufficient enough to cease the blood flow from the uterine vessels to the uterus. So that is a sufficient. Here, while tightening the knot, care should be taken that we do not overshoot. So now we will try to separate the utrovesical fold of peritoneum away from the cervix. Here we need to remove all the contents of the scar pregnancy and excise the scar area and approximate the ends. So for this we need little more longer dissection than routinely we do it for a hysterectomy. In this case, we use the anterior approach, as there's a thick band of tissue of fibrosis between the uterovesical fold of peritoneum and the scar. As we are aware that scar pregnancy happens at the site where there is a poor healing of the scar. So we should anticipate a dense fibrous tissue between the bladder, uterovesical fold of peritoneum, and the scar area. So whenever we do the dissection, try to do fiber by fiber dissection. Identify the bladder, cervix separately, and do gentle dissection. And dissection should be sufficient enough to expose the scar site and expose the cervix amount sufficient enough to excise. Even after excising the scar, there should be sufficient amount of cervix should be available to approximate the proximal and distal end of the excised part of the scar area, so that a recurrence or isthmosal formation, scar dehiscence, does not happen in future. So for this, we are using the harmonic scalpel, which has got a less lateral spread, and we are identifying the fibrous tissue fiber by fiber, and then we are doing the dissection to keep the bladder well away from the cervix. We can see we are identifying the fiber by fiber, identifying the bladder clearly. I'm holding the bladder in the left hand, lifting it up, identifying the fibrous tissue, dense fibrous tissue, and dividing only the fibrous tissue. And it is also being divided millimeter by millimeter. We are not taking a big chunk at a time, as inadvertently we may open the bladder in this case. And the vascularity at the scar pregnancy will lead to more amount of blood loss, or we may go in a wrong plane. So keeping medial and superficial to the uterine artery is also one more very good clue to keep the plane between the bladder and the cervix area. Once we are done dissection on the left side, we are going to do the same similar dissection on the right side. Scar pregnancy is in the rising trend, as there is a rising incidence of cesarean section, and a closure of the cesarean scar is very important, even without a postoperative infection. There are studies which shows that it may be because of the single layer closure, but there are studies which are not convincing that it is not because of the single layer closure. It could be because of the associated comorbidity like infection, poor healing, and other repeated cesarean section, a less span of time between the two cesarean section, not allowing the enough amount of time for the complete healing. Maybe the reasons for the development of the isthmosal or poor healing of the scar dehiscence. Now we can identify the properly the fibrous band of tissue and separating the bladder clearly. So now we are taking a good chunk because now we are aware that where is the bladder and where is the scar tissue. Till then we are doing dissection fiber by fiber, millimeter by millimeter. And we can see even with this delicate dissection, there is a staining of the area with the blood as there is a very high level of vascularity due to the anastomotic vessels of pregnancy and also chorionic tissue which is invading deeper into the very fewer cervical fibers or lower segment. So now we are having a properly separated the bladder well away from the cervix. Now we are getting the proper plane. So now once we identify the plane, it becomes very easy to separate the cervix from the bladder. Till we get this plane, we should be very delicate in our dissection. A smooth, shiny cervix is very clearly appreciated now. So now once we are in the proper plane, then now the dissection can go little faster. So that is the cervix and anterovaginal wall can be clearly seen by that's the cervix, which is very well separated well away from the site of the scar area, sufficient enough to evacuate the contents of the scar pregnancy. And after identifying the scar area, we can excise very well. Now we are planning to open the contents, make an incision over the anterior wall close to the site of the scar pregnancy, and then aspirate all the contents clearly, excising the scar area, and then we are planning to suture it back. So Orman scalpel is used in active blade. Take a deep incision inside the site of the scar. This is a lower segment at the junction of the cervix and the uterus near to the isthmus. In the central area, we made an incision. Nearly half a centimeter incision is made, which is extended. So now we are aspirating the contents with the suction sleeve. We should aspirate all the contents so that there is no persistence of the chorionic tissue and it should not continue to grow again. So we can identify that that is a products of conception. So it has been seconded in toto. So incision is made at the site of the scar area, and dense fibrous tissue or poor fibrous tissue which is being excised so that we can approximate the muscular fibers. So all around the fibrous tissue is excised. So that was the site where the pregnancy was there. A scar is excised. For confirmation, we keeping the uterine manipulator so that we do not obliterate the uterine cavity. Or you can put a number 8 Egas dilator into the cervical canal and into the pass into the uterine cavity and approximate over that. So trying to introduce the uterine manipulator into the uterine cavity so that while approximating, we do not obliterate the cervical canal. So while taking the bite to the scar tissue, care should be taken that we do not take a bite through the vessels which are very close. Uterine artery enters into the uterus at the level of the isthmus. So most of the time, scar will be present at this area. So we should be careful that we do not puncture the vessel. We are taking a simple stitch. It can be done with the barbed sutures as well, which will be faster way of completing the approximation. But most importantly, we should approximate muscle fibers to the muscle fibers without obliterating the uterine cavity. Only anterior wall should be sutured, should not include the posterior wall while suturing it. So the muscular fibers are very tough. So you should have a tight approximation so that healing becomes better. So now this is the left edge of the scar. We're taking the bite through the full thickness of the proximal segment and then taking a full thickness through the distal segment and approximating it with a knot. Number one vicryl is used for this. So like this, you should take the full thickness where we can see the uterine manipulator, which prevents the taking a bite through the posterior wall of the cervix and the uterus. So now we shall understand the importance of dissection of the bladder well away from the cervix. So it need to be excised full length of the scar, freshen the edges, and then you should approximate so that uh, very good healing. And again, once again, scar dehiscence or isthmusal formation does not happen. So this is the final stitch we are taking at the left end of the scar. So full length scar is approximated from left to the right. So now we are trying to remove the shoelace pattern ligation of the uterine artery. So the temporary ligation of the uterine artery, which was seizing the blood flow to the uterus, should be pulled slowly with the counter traction under vision so that we do not injure the vessels while doing this. So this is a very good way to prevent the uterine artery supply to the uterus during our procedures. So it was done on either side. We are showing it on the one side. Similar procedure was done on the other side also. Interseed, that is oxidized cellulose, is used to cover the suturing site to prevent the adhesion formation. So this is a complete procedure of scar pregnancy management. Thanks for watching this video.